Yeah. So, good morning, everybody. Thank you for being here, and thank you for the invitation to give this talk, during which I would like to share with you mostly some of the preliminary data of a study we are conducting in 3 centers in Italy. So, these one conflicts of interest which are not really relevant for the present talk. We do know that mechanical ventilation is associated with the dysfunction of the diaphragm, with loss of diaphragm mass, loss of contractile power. And so this was one of the first papers by Levine about 10 years ago on the relevance that mechanical ventilation had in causing diaphragmatic induced dysfunction. And then after that, many reports underline the clinical relevance for our patients who are being weaned from the ventilator in the presence of diaphragmatic dysfunction. This is another paper that was published during the same year by Samir Jabber, where not just they have shown that mechanical ventilation is associated with diaphragmatic injury, but they have also shown that the longer the duration of mechanical ventilation, the worse the diaphragmatic injury would be. And so this does not necessarily imply that if we keep some spontaneous breathing will revert this effect, but for sure it indicates that the longer the patient stays without respiratory effort, the worse the diaphragm will become. This is an animal study in which the authors did tackle this question from the group of Scott Powers, and they have looked at the difference in 4-henoxyanoenolase, which is a marker of oxidative stress in the muscle. They have compared different conditions, so controlled ventilation and different forms of controlled mechanical ventilation with 12 or 18 peak inspiratory pressure or assisted ventilation. And interestingly, what they have shown is that if you use a lower level of pressure support, you are basically able to keep, to keep the diaphragmatic dysfunction, to avoid diaphragmatic dysfunction and keep the level of oxidative stress close to the controls. But if you do use higher levels of pressure support, where in this case these were animals, were just sort of triggering the ventilator, you would not really benefit much from the presence of spontaneous breathing, and the level of injury you get is more or less what you get during controlled ventilation. So I think this study, which again is done on animals, suggests that yes, assisted ventilation and presence of spontaneous breathing can preserve some diaphragmatic function, but it's not just a matter of the type of the ventilation we use, it's more a matter of how much the animal or our patient is actually breathing. And several data, 2 or 3 very nice papers came from the Toronto group in the last few years, mainly by Ewan Gallagher, who has shown how ultrasound can be powerful in tracking the evolution of diaphragmatic dysfunction. So what Ewan has shown in this paper here is that if the patient has a diaphragmatic thickening, which is an indicator of effort of the diaphragm, which is around 20–25%, this will be associated with a shorter duration of mechanical ventilation. However, if the diaphragm is put completely at rest and there is no contraction of the diaphragm, this will be associated with a longer duration of mechanical ventilation. And also, if the diaphragm is contracting too much, this will be associated with a longer duration of mechanical ventilation. So again, these results show that as compared to a fully passive patient, the presence of some spontaneous breathing activity can preserve some of the diaphragmatic function. And this finding is corroborated by this finding here that shows that if the baseline thickness of the diaphragm, so just looking at the thickness of the diaphragm at the end of expiration, if that stays rather constant over the course of the disease of the patient, this is associated with a shorter duration of mechanical ventilation. Whereas if the diaphragm becomes thinner, so loses thickness or increases its thickness, this will be associated with a longer duration of mechanical ventilation. And this excellent study follows up another study by the same group where they followed patients during the first 8 days since ICU admissions, and they were able to separate 3 patient populations. You see here in green those patients in whom diaphragmatic thickness remained constant over time. And this was almost half of the patient, 44%. And then these were the patients who had the best clinical outcome. These patients survived more. Whereas these guys in red here were those patients in whom the diaphragm had lost thickness, had lost mass. And so, not surprisingly, these patients died more. Or it's clearly the first time that this was shown, but this was what you would expect. However, it's interesting to notice that there was a minority of patients, about 12% of patients in blue in this plot, in whom diaphragmatic thickness from the baseline increased over time. And also this patient that in Golliger's study was, as I say, a minority, these patients had the worst clinical outcome. And when I saw this paper, when we saw this paper, we discussed a lot in our department how this could be the case, and also discussing with the authors of the papers, we were wondering whether this would be a marker of the severity of the patient, so the most severe patients were somehow struggling to breathe, and so their diaphragm became stronger and thicker, or if this was a marker of a sort of diaphragmatic injury, some sort of edema, and so the diaphragm would become thicker because of an injury. So we decided to set out a small pilot physiological study, and I will be showing you the results, the preliminary, or I would say interim results of this study in the next few minutes, which I highlight as still preliminary. And our primary aim was to evaluate the change, the effect on the diaphragm thickness and thickening of switching from controlled ventilation to assisted ventilation. In our ICU, I would say in Italy generally, we don't use much assist control. We tend to keep the patients on controlled ventilation, and then when they can be switched to assisted ventilation, we switch them typically to pressure support. So we took advantage of the fact that we had 2 real separate periods in controlled and assisted ventilation to study the evolution of the diaphragm. And then we had some secondary aims, which were again to assess the change in diaphragm thickness only during the phase of controlled ventilation, and also to affect the clinical factors associated with the change in thickness, to assess and try to understand a little bit whether this was a marker of injury or of what else. So these were our inclusion criteria, very simple. Patients intubated or tracheostomized who were undergoing controlled ventilation since at least 48 hours, only with short intervals of assisted ventilations were allowed. And exclusion criteria that mainly relate to the technical issues of performing ultrasound, so very high BMI, the presence of abdominal vacuum therapy, and those kind of things. This is the study protocol. After 48 hours of controlled ventilation, patients were enrolled. And then at some point, according to the clinical judgment, this is just observational study, so where clinician decided to switch the patients on assisted ventilations, patients passed on to pressure support. We collected a set of baseline data, and then every 48 hours we collected clinical data, and we performed an ultrasound measurement of the diaphragm thickness as described in the literature. Now, for the rest of the presentation, it's important that what I will call day 0 is the day in which the patient was switched on assisted mechanical ventilation. So all patients have a day 0, and then we call day -2, -4 the preceding days on controlled ventilation, which will be different between different patients because this period can be different. And then we have day 2, day 4, and so forth for the period spent on assisted ventilation. This is the way we measure diaphragm thickness, which is nothing new under the sun, and again there's a very nice paper describing how this can be done, but you basically use a linear probe and you get two very hyperechoic lines, which are the pleura and the peritoneum. You do this measurement on the right, so the liver provides an excellent contrast and sort of keeps the diaphragm attached to the chest wall. And so this would be the thickness of the diaphragm. We took the records at the bedside and then analyzed the images offline just to make sure to take appropriate measurement and to evaluate the reproducibility of the measurement. So this is the thickening fraction of the diaphragm, so which, as I say, is an indicator of the strength that the diaphragm, the force that the diaphragm is generating. So this goes back to one of my first slides, and what this slide highlights is the fact that we were quite able to separate the two phases. So during controlled ventilation, patients were really passive, and so there is basically no thickening going on in the diaphragm. And during the assisted ventilation, patients were actively breathing. I would also like to stress the fact that this was the data of this study were obtained offline, so clinicians were not aware of these data, were treating the patient, but just for clinical management, our patients had a thickening fraction in between around 20%, which, as I've shown you before, is the thickening fraction that seems to be associated with the best patient outcome. So just for clinical judgment based on other indicators, the doctors selected the level of assistance leading to an optimal, if you allow me, thickening fraction. So what are our results in terms of diaphragmatic thickness, which is again an indicator of the trophism of the diaphragm? As expected, if you look at what happens during, I spoiled it, during assisted mechanical ventilation, you see a decrease in diaphragmatic thickness down to a level of what we call 100%. So we normalized all the patients to the thickness that they had on the first day of assisted ventilation. So not surprisingly, nothing new under the sun, but still I think it's something worth replication. We show that during controlled ventilation, diaphragm thickness drops. However, when we restore diaphragmatic activity, switching the patient on assisted ventilation, we see that diaphragmatic thickness goes back more or less to the baseline level in average of the patients, or even a little bit higher. So in terms of what was our primary outcome, we do show that assisted mechanical ventilation restores diaphragmatic thickness to the level, to the initial level. We can also divide the patients, like Golliger did, in those patients in whom the thickness during the assisted phase of ventilation increased, and in those patients in whom remained stable. So first of all, as you can notice here, we got a much higher fraction of patients in whom diaphragmatic thickness increased. It was only 12% in Golliger's study. Here is 65%, and this is due to the fact that we are studying the patient perhaps at a later stage. We are looking at the recovery. So going back to our question, this increase in diaphragmatic thickness, is it injury or is it recovery? And I have no answer, no final answer to that. I have some hints. First of all, if we look at the patients with an increasing thickness, we see that this patient had a more negative fluid balance. So the change in thickness is not entirely explained, or at least there is no data that suggests that this change in thickness would be explained just by edema, because patient, despite a very negative fluid balance, had an increased thickness in their diaphragm. Where these patients, those patients in whom diaphragmatic thickness increased more severe, again, it doesn't seem to be the case. Peak level were not different, and once again, our power is very small, but so there is no statistically significant difference, but there is not signal either. Peak level was not higher in this patient. Compliance trended towards a higher value in these patients in whom the diaphragmatic thickness increased, and also pressure support level was slightly lower. Once again, the numbers are very small, but if we just take a look at mortality, we see that the presence of increasing thickness is not associated with an increased mortality. The mortality rate was actually lower in these patients than in those patients in whom the thickness of the diaphragm remained stable over time. And once again, take this result with caution. So, oops, I finished my time. In conclusion, I think that spontaneous restoration of spontaneous ventilation after controlled ventilation is associated with the recovery of diaphragmatic thickness, which at least in this small study does not seem like a sign of injury, but rather a potential indicator of recovery. Thank you very much for your attention.